Assalamu alaikum. Hello and welcome to webinar number 4 of the Patients with Headache series, endorsed by SSMC and SAHA. This webinar is supported by Eli Lilly. My name is Gerard Moore and I am the organizer and support manager for today from Focus Gulf Conferences. The date is the 12th of October, 7 p.m. here in the UAE. This webinar is being recorded and will be available after the webinar has finished. You will be able to write any questions or comments to Dr. Samer and Dr. Ahmed in the chat bar located on your right-hand side. If you have any technical questions or private questions that you wish to remain anonymous, you can type into the admin-only question bar located on your chat bar. If your video or audio is breaking up, you can press the red reconnect button located at the top of your screen. For now, I will now hand over to the moderator and chairman, as always, Dr. Ahmed Shatila, consultant neurologist at SSMC. Dr. Ahmed, the floor is yours.
Thank you, Gerard. First of all, I'd like to thank everyone for attending this webinar today. As always, I'd like to thank the audience because without your support, these webinars could not actually come to fruition. Today, and before that, I'd like to thank our sponsors today, Lilly, that is sponsoring the lecture on depression and migraine. Is there a link? I'd like to thank SSMC for hosting the webinar and Gerard from Focus Gulf for making this webinar possible. Today with us, we have Dr. Samer Makhoul. He is a psychiatry consultant at the American Center of Psych and Neuro, and he's going to talk to us today about depression and migraine. Is there a link? Dr. Samer, the virtual floor is yours.
Thank you so much. Thank you, Ahmed, and thank you, Gerard. And actually, thank you all for attending this webinar. I think it's always an opportunity for us to do anything to raise awareness about mental health, because I think that's a passion we have. And I think webinars like this and meetings like this are amazing because we can reach out to a lot of people, patient, physician, and everybody, and hopefully that would be helpful for everybody. I'll speak in English. The slides are in English. However, I know there are some Arabic speakers, or maybe a lot of Arabic speakers here. So what I'm going to try to do is deliberately I'm going to speak a bit as well in Arabic to try to translate and try to explain things together. So that's my plan for today. And I'm going to focus on depression and migraine. So we're going to talk a little bit about depression, migraine, and the link between both of them. So that's my plan. I would love to hear a lot of your questions at the end, so please make sure you type them. We're going to try to speak for until 7:30, which is 26 minutes from now. And following this, hopefully we're going to have an interactive sessions to answer all your questions. History of depression, تاريخ الاكتئاب. So depression has been described for thousands of years. So that's because there's a lot of people that think it's something new. It's a whole bit of lifestyle now. People are depressed. The old days they were not, or like even let's say 50 years ago there was nothing like depression. No, actually it has been there for thousands of years. We're talking about ancient Egypt. They called it fever in the heart, the dryness in the heart. Ancient Greece, they had it imbalance in the 4 basic body fluids. 18th century and early 19th century, depression was an inherited and unchangeable weakness of temperament. يعني الاكتئاب مرض صار له زمان كتير مو عم نحكي على شيء جديد او بدعه عم تطلع من العالم ليعملوها. لا، الاكتئاب صار لنا زمان وعندنا كتير ادله على انه قد قديم. So it is evident from the past and is not like something that we just came with and created in this century. This is one of the nice slides. When you try to speak to other people, and especially if you speak in purely with doctors, they love to have those busy slides with very, very, very big amount of numbers, and you cannot read anything. But I did put an arrow here to say depression is affecting 16% of people. That's from the studies. That means 1 in 6 people almost they have depression. يعني 1 من كل 6 أشخاص عندهم اكتئاب. وهذا الشيء كان عم يكون من أكثر الأمراض المنتشرة بالعالم. This has started in studies they did by the WHO. They said in 2004 they looked at the 10 leading causes of the burden of disease. So that means those diseases that causing disability, they have like a significant amount of disability. And depression was number 3 in that 2004. And diabetes, for example, you can see like at the bottom. So depression was 4 times more. While if you look at 2030, they estimated that's going to be number 1, and diabetes would be higher. So we're talking about depression is more than ischemic heart disease. You know, it's not an ischemic heart disease, also heart disease. Then, if you look at that, when I say with a ischemic heart disease, even though it's increasing, and we know a lot of people they are on tablet for blood pressure, for heart conditions, but the depression is ahead of them. And we were thinking that in 2030 it'll be disease number 1 because of the following. It's very common. It's more than 300 million affected. And at worst, depression can lead to suicide. We know that almost 1 million, so it's like 800,000 people die from suicide each year. And suicide is the 2nd leading cause of death in young people after a traffic accident. So we're talking about a significant number of deaths come from suicide. And, you know, we're not going to talk about suicide much in the presentation itself because there's a lot of taboo around it, but suicide is a disease. Nobody is protected. There's some risk factors, but nobody can escape suicide as a sign of depression when it comes very, very severe and untreated. To our surprise, it was decided, it was like, you know, studied that it was the number 1 causes of disability in 2017. So we were 13 years ahead of ourselves in terms of having depression as the causes of disability. You know, we said in 2030, but no, it was, you know, the number did rise a lot. And at the same time, other diseases like, you know, respiratory diseases and the other diseases, we were better in treating it in Africa. That's why I think depression becomes number 1 that quickly. So what is depression? Depression or mood disorder comes with a lot of things. We're going to talk about what it is. But, you know, for us, we think depression comes by itself. الاكتئاب ما له مرض بيجي لحاله. الاكتئاب موجود مع كثير أمراض عنا، أمراض نفسية، أمراض عصبية، وأمراض داخلية كاملة. واحدة منها اللي عم نحكي عليها اليوم، الاكتئاب بيجي مع المايجرين، مع الصداع، بيجي مع أمراض الألم، بيجي مع السكري بنسبة عالية كتير، بيجي مع الأمراض القلبية بنسبة عالية كتير، بالإضافة للأمور الثانية النفسية اللي هي مثل القلق، اضطراب فرط النشاط، اضطرابات شخصية، واضطرابات التغذية. So what I was saying, depression doesn't come by itself. It comes by itself, but it is very, very, very common and very widely seen coming with a lot of other conditions. Migraine is one of the topics we're having today. Pain, you know, a lot of comorbidity comes with pain disorder, with diabetes is very high, and the outcome of diabetes is usually very bad. When we have depression and diabetes, the same thing with cardiovascular. It comes with obesity, it comes with epilepsy, for example, and other neurological diseases. And at the same time, depression comes as well with other psychiatric conditions. You know, we might have it coming with anxiety disorder, with eating disorders such as anorexia and bulimia. It comes with substance abuse. It comes with personality disorder or ADHD. So we tend to see mood disorder or depression commonly with other diseases, or very commonly with other diseases. So what kind of symptoms of depression, you know? And we're going to talk about those symptoms that we see. It is changing in eating habits, such as overeating or loss of appetite. So it can be either. Some people, they say, when I'm depressed, I eat a lot. But probably the most we see, especially with medium to severe depression or the severe, is loss of appetite. Feeling of sadness. We say I'm depressed, أنا حزين, أنا مكتئب. But those feeling of sadness, they are very strong, and they are most of the time, most of the days. Unhappiness, hopelessness, or quite negative pessimism. We see irritability, agitation, restlessness, or frustration, like you cannot sit still. So if you're watching this webinar, you feel like, oh, I need to move, it's too much pacing, hand wringing. Loss of interest or pleasure in activities that were once pleasurable. So things I used to love to do, maybe watching the movies, going out for dinner, spending time with the kids, whatever it is that people used to love, it becomes less of a loss of interest, or sometimes it becomes even, when it's severe depression, becomes like, like torture, عذاب. ما عاد فيني خلاص، ما عاد فيني أتحمل، طلع مع أصحابي كتير صعبة. It's very difficult to go out with a friend, which usually would be the best thing I would do, so it becomes like a torture for me. Obviously, people who are in relationship, their libido, the sex drive goes down, they don't feel interested in this, feeling of guilt or worthlessness. The guilt doesn't have to be on something major I've done now. It can be on something like, silly happened about 15 years ago, 20 years ago, something, minimum, but still I just ruminate and feel guilty about it. Lack of energy, fatigue, or tiredness is one of also the cardinal symptoms of depression. People feel tired. There's no power. There's, they need to push themselves. They have difficulty in concentrating, thinking, making decision, or remembering. So making a decision tends to be very hard, when you have depression, So you're kind of indecisive. You just, think again and again, and 1 minute you feel yes, another minute you feel no. Change of sleep, such as insomnia or increased sleep. I would say, if I'm gonna say one of the non-cardinal symptoms, obviously we cannot have depression with when people are enjoying their time and people are, happy and full of energy. It has to be some of those, one or two of those symptoms. But the other symptoms that we tend to see almost in all cases is people having problem with sleep, mainly insomnia, difficulty to get to sleep. Very important also, we have something what we call somatic symptoms. Unexplained physical problem, such as headaches, pains, cramps, backaches, digestive symptoms. They feel like people like as if there's like heat, or like they feel like fire at times, in their body. It's kind of, aching, back pain, headaches, and that's obviously we're going to talk about migraine, but it is there. And they cry for no apparent reason. That is, one of the symptoms that we tend to see with depression, and that is, you're just sitting down and just, there's tears in your eyes, and you feel, you cannot control it. So I had a lot of meetings in the past, and in those meetings, I've got people saying, "Oh no, depression is not here. It doesn't exist here." It is 16% all over the world. So there's nobody anywhere on earth are immune from depression. It's equal in almost everywhere, more or less. When I say equal, like with a range. And this one, they looked about the burden of disease I showed you earlier from all diseases, and we look at all ages in UAE. And so the things that are in blue, in the بالأزرق, there are diseases that are on the rise. The things are in gray, there are diseases that are becoming less. So we're doing good job in dealing with those ones, while the ones with blue, they are increasing. And this one, they looked at, I think, 15 years together, from, I think, I cannot see the numbers here, but it's, I think, until 5 years ago. And this one, the first slide, they looked about all ages, so young and old age. And obviously, when you have old age, you have all the physical illnesses. And as you can see, depression has a big box because of how common it is, and it is on a rise. So that is blue in color. When we look at that for younger ages, and we see the burden of disease, we see depression is one of the highest one we have. Unfortunately, we have drugs as well, because there's increased drug misuse in the in the younger population. And then we have diabetes, which is as expected in this part of the world. We have high genetic and high level of diabetes. But if you see the amount of the big box of depression and where it is located, it tells me it's one of the things that is we need to pay huge attention to here in the UAE. When we look about younger age, that's people less than 50. This is main years of being able to produce and to be able to provide and all of that. So we see those are cause a lot of burden of disease and disability. So depression is a disease that comes with a lot of heterogeneous character to it. Because if we try to put it together, so try to put it into three areas that interact. We look at cognitive abilities, which I'm going to say what's that, emotional abilities, as well as physical symptoms. So the cognition, which is now is the main focus we have at the moment, because historically we looked at the emotional part, but the cognitive part is we're talking about attention and concentration, short and long-term memory, planning and organization, mental sharpness. And mental sharpness and decision making are the ones that usually the signs that tells me this person has fully recovered. You sit with them, they're sharp. You would expect them to be sharp, if they are well, and that's what you need to do. Word finding, the ability of using words in general, and thinking quickly, think speed, and making the right judgment. So all of those are our cognitive ability, and they get severely affected with depression, and that's what usually other people see around us. The common one, which anybody I would expect to when I ask them to say, what do you see in depression? شو بتشوف إذا كان حدا مكتئب؟ بيقول لك بيكون حزين، متوتر، عنده عصبية، ما عم يقدر يستمتع، عنده شعور بالحزن، بيفكر الحياة ما لها طعم، بده يقتل حاله أحيانا، ما في أمل بالمستقبل. Symptoms like the sadness, anxiety, lack of enjoyment, suicidal thoughts and ideation, hopelessness. All those are the emotional part, which is, I think, even the patient who never experienced depression or never heard of depression, they would be coming with this list because it comes with the definition of the word. However, people don't look at those symptoms that I'm going to mention now. When we look at those, they don't usually connect them with depression. Even physicians, they don't connect them with depression at times when they don't have enough awareness of them. Fatigue, headaches. Obviously, we talked about the sexual part, the eating, losing weight. We go and we look at a lot of things, other than, whether that's depression, or when you gain a lot of weight, chest pain, stomach problem, digestive problem, we look at IBS, we look a lot of other things, the psychomotor symptoms, and, pain at times we see. All those physical symptoms, usually when they go and present to the general physician or specialist, they go on and on and on and investigate. And sometimes they miss asking the patients the simple questions to check whether they are, depressed or they are happy. Those symptoms, they have an impact on our functioning, and mainly the cognitive dysfunction is what affects us in our day-to-day things. So how severe is depression? Obviously, like every illness, there are different severity of the illness. One is we say people are, they have symptoms. Everybody would have sometimes when they are feeling depressed. So we have one or two symptoms. So not everybody would say, I'm not sleeping well or I'm not eating well. I would say they're depressed. So when there are very few symptoms, those we call about them is they are not depressed at all. When we go to mild depression, which is we talk about 4 symptoms, and the 4 symptoms, they have to be very clear 4 symptoms, and they have to be consistent for a period of time, and that usually you need to have those symptoms present every day. So it's not like, I was not sleeping on Monday, Wednesday, and Friday. It has to be every day for a period of a month or more. What we look about moderate depression is obviously more symptoms, and when we look about severe depression, it will be 7 symptoms. And sometimes it comes with psychotic feature, which is a severe depression when people lose contact with reality. Differential diagnosis. So what comes with depression? We have a lot of things comes with depression, but sometimes we have diseases that they comes and we are thinking that is depression while there will be something else. Dysthymia, which is, it's a low mood, حزن مستمر, بس فقط حزن مستمر. Only low mood for a long period of time, usually about 2 years. Bipolar اضطراب ثنائي القطب. mood disorder, rapid cycling. personality disorder اضطرابات شخصية. anxiety disorder اضطرابات القلق. And there's other conditions that they might come with some depressive symptoms, but we must misdiagnose sometimes unless we take the true story from the patient. migraine الصداع الشقيقة. Headaches disorder are among the most common disorder of the nervous system. So we talked about depression is one of the most diseases that causing disability, but obviously headache disorder are the most common. I think there's nobody did not experience headache. So it's not we're talking about 1 in 6, probably 1 in 1. It has been estimated that almost half of the adult population have had a headache at least once within the last year. Headache disorder, which are characterized by recurrent headache, are associated with personal and burden on the society because of the pain, the disability, damaged quality of life, and that has a lot of financial cost. And unfortunately, everything in the world we look at it when we have public health and when the government do planning for the health sector, they look about what's the financial impact on that. And we know that worldwide, the minority of people with headache disorder are diagnosed appropriately. So we know there's so many undiagnosed, and that have an impact on them, having to take days off work, having to impact on their family life and stuff like this. So it is usually underestimated, under-recognized, and under-treated throughout the world. And obviously, third world countries, they will be the worst in this because of lack of awareness. Is there any depression and migraine link? So doctors and researchers have long drawn a link between migraine and depression. So we know that as doctor. And what I'm going to try to do in the next few minutes before we come to the question is try to tell you a little bit of science, شوية علم behind the links, in some of the studies, about links between depression and migraine. So several studies have shown that the presence of one of these disorders increases the risk of a person suffering from the other disorder. So when we have depression, we're more likely to have headaches. When we have headaches, we are more likely to have depression. That's what when I say there's links. But the most common two things that come together, we call it depression and anxiety. So they tend to come together, So it's not like, some people, they would say, depression and anxiety, they overlap like this, and sometimes they cause them almost the same risk. Migraine and depression might be related in several ways. So they both may be caused by similar brain chemicals. So that's what we think from the studies. Also, because migraine are responsible for severe pain and disability, the migraine attacks and reduced quality of life may lead to depressed mood, while the mood changes may trigger migraines, as can many other conditions. So if we try to put that, so we have somebody with migraines and they have severe pains, that has an impact on their mood, and that sometimes when it is a chronic migraine by itself causes clear depressed mood and might lead to triggering depression. And when people have mood changes, that might trigger migraine cases as well. And that's patients with migraines, they know that clearly. In one of the studies in 2016, they used a large sample of Australian twin pairs. And usually when we have a twin study is the studies that we look at, tells us the genetic factors. And they wanted to know how much genetics underlie depression and migraine. Result indicated that for both broad and narrow definition, the observed comorbidity between migraine and depression can be explained almost entirely by shared underlying genetically determined disease mechanism. So we know it's not a coincidence. So we know if one and another twins, when there's a link between ones, also when they're going to have both, there's a clear genetic factor. في عامل جيني عالي جدا بالunderlying migraine and depression together.
5 more minutes, Dr. Sam.
Thank you. Authors identify 360 migraine cases, so we're talking about a quite large number of cases. In this study in 2010, they had about 210 of migraine without aura and 151 cases of migraine with aura. And they found the odds ratio for depression in patients with migraine were 1.29. So that means like 1 and 3%. So they're higher than they would expect it to be 1 to 1, but no, it's higher. And for patients with aura, it's significantly higher. We're talking about 1.7. So almost doubling, the number of estimated cases that you'd expect. So if we expect people to have 16% cases that they will have depression, that will be doubling from 16 to 32%. So that's what they mean is the odds ratio of that. So that means increase. And we know that genetics are very significant, with migraine and the depression, and we know those cases had, as we said, genetic correlation. Shared genetic factors, in that study also concluded that there is a clear relationship between both, especially with migraine, with aura, and depression. We're talking about a recent study, narrative review reported on the current literature. They found epidemiological finding indicated there is also a clear relationship between migraine and depression, with one disorder increasing the risk of the other and vice versa. So this is very interesting. If we had depression, then we're more likely to have migraine, and we have migraine, we're more likely to have depression. And the twin and family study indicated that this relationship can be explained at least partially by the genetics that we talked about. And there's a lot of genes that they were identified, and I just put them here just to show that it was done thoroughly. Treatment goals in depression, that will be my last slide. So when we talk about depression back in the 70s, we want people to feel better. So we look at response. So we don't look about trying to control all the symptoms. In the 90s, with the newer medication, we started to call about remission. And remission usually that means I improve significantly, but there are still some symptoms that they might still there. Going into now, expectation now, we look about diseases now. The expectation from doctors when patients, they have disease, to have full functional recovery. I need to go back exactly how I was or even better. That's what people ask for when you do gallbladder surgery. You are, before you stay for a month, maybe struggling with recovery. Now you go back to your work sometimes in the second day. And people expectation now to have full functional recovery. And I think we are almost there, if not there, in a lot of cases of depression and the recovery of that. So finally, for people who are not in Abu Dhabi, this is a picture from my bedroom in Reem Island. Not today, obviously before. So that's for you, to encourage you once things are better to come and visit Abu Dhabi and keep safe all.
Dr. Samer, thank you very much for the very interesting and informative lecture. Much appreciated. So I have a question. I'd like to start off the Q&A, since it appears that we do have a lot of interest and a lot of questions being posed tonight. When we talk about headaches and depression, it's not now from a neurologic point of view. I tend to focus more on the headaches, and from a psych point of view, psychiatry, you may focus more on the psychiatric point of view. But most of the time, it's interlinked. It's not really just migraines, and it's not just depression. It's usually more of an intertwined problem. And as you said, one may cause the other, and the other may cause the first. From my point of view, I sometimes notice that even when I treat migraines, they may still have an underlying depression. When you see patients in clinic, when they come in depressed, and if they have migraines on the side, do you notice that their migraines improve if their depression improves?
Absolutely. So one improve if the other improves, but it's very important to recognize there are two different conditions. So most of the time we need to treat both. And we know, you being a neurologist, since I started working in the Psychiatry and Neurology Center, we just noticed, we did a study to show the high link between neurological and psychiatric disorder, we found a much higher percentage of patients with neurological diseases. When we screen them, we find depression and anxiety specifically. So it is very important to ask. Sometimes it takes 20 seconds for you to kind of fish for depressive symptoms, and that would comes with a very simple questionnaire. At times we're doing it even in receptions outside.
Very nice, thank you. How do you overcome some of the issues and the taboos in society when people, and this is a problem I face a lot when I tell my patients I want to send you to a psychiatrist, and no, there's a certain taboo among patients with psychiatric illness or who suffer from psychiatric illness. What are some methods or what are some techniques that you found useful to help explain to people that this is truly a medical illness, just like migraines are a medical illness?
I mean, this is the reason why I'm here. This is the reason why we try to raise awareness everywhere, because the stigma is so high. The stigma is so high in depressions that stop patients and physicians and families from providing support to the patients. So I will just say a little bit. The stigma is not just in the third world country or in the Middle East. Stigma actually it's everywhere, and that's why you see, for example, people like Oprah Winfrey in the U.S., which is one of the most famous hot show. You see the Prince in the U.K. talking about depression and issues around depression. So people everywhere trying to raise awareness. But what I would say to answer the question specifically, I would say treat depression. Don't send to a psychiatrist. Depression, because of the high rate, it's impossible to be treated by psychiatrists. I would say psychiatrist's role is to treat the difficult to treat depression, which is not just, neurologists, they have a lot of expertise with this, but I would say family physician, OB/GYN, gastro, everybody should treat that and should give the treatment, whether it is medication, supportive, depending, because it's simple to treat, and it usually have an excellent response rate.
I totally agree with you. Thank you. Gerard, it looks like we have a lot of questions, so we'll start with some questions.
Thank you, Dr. Ahmed. Thank you, Dr. Samer, for, as always, an amazing presentation. And as expected, we've had quite a response both on the public chat bar and on the private questions as well. So we have 25 minutes roughly left, so I will try and get through as many of them as we can, but we apologize if we cannot get through all of them. The first question, and I'll start from the bottom. Is my psych meds causing headaches as a side effect? Do you know this?
I don't know what psych meds you have, but yes, in real life, yes, there are some, or not some, actually many medication, antidepressants, they cause headaches as one of the side effects. However, and that's a big however, I would say almost all, not all, almost all, they are transient and they usually go away within days or like a week or two in all the antidepressants. However, there are some medications that stay in our system little period of time. So some medications stay for days, some stay for a day or two. If I keep forgetting those medication, so if I'm not very compliant, I take them every other day, I would have this recurrent headaches because it goes up and down in my system, up and down, and one of those symptoms would be headaches. So that might be a cause of headaches as well.
Okay, thank you. I think you partly answered the next question as well, but I will ask it anyway. Should I take headache medication? I do not want to take more meds if they interfere with my psych meds.
They don't interfere with your psych meds, so you can take the headache medication. Most psych meds, they have very little drug interaction, so very, very few, and your psychiatrist would tell you, I would say maybe I can count them 2 or 3 that they might have drug interactions. So please take your headache med because they are 2 different conditions. They interact, but they are 2 different conditions.
And I can also comment that some of the newer treatments for migraines definitely do not interfere with psych meds, especially the monthly injectable medications. They do not interfere with psych meds. So that's something to keep in mind.
Thank you. This person claims they are having issues with memory. What do you recommend they can do to help resolve that?
So memory is, if you notice, and that's probably, people talks about depression in general as they give presentation, but maybe I did go quickly with one of the two slides about the cognitive ability, but memory is part of cognition. And I think cognition has been always neglected in depression diagnosis. And I think this is one of the core symptoms. And this is the most important one to get to full recovery. And that's what I said. Usually those symptoms, they don't get better. So sometimes a lot of medication, they do not treat cognitive problems that comes with depression. So depression can cause concentration, that to get worse. As the concentration, when it gets worse, that would have an impact on memory, but it's not like memory itself. So we're talking about registering and cognitive ability. And we need to treat depression properly, fully, to be able to get over this. So that would improve our our concentration and cognition, and that would improve the memory.
Excellent.
My headaches cause me depression. I've become a different person. I have changed diets and sleeping, but still feel bad. What should I do next?
I mean, the first thing is, I would say, look at other treatment of headaches that can be fully controlling the illness. And I do believe there's the treatment day after day. We see new medication. I'm not even following up myself, so I wouldn't know half of the new treatment. So I would say treat the headaches fully. And then if there is depressive symptoms, or we can diagnose depression, then we can treat that. But initially, I would need to treat the headache fully.
I agree.
Is there any role for yoga or Ashtanga for the treatment of depression, or any other medicine for that fact?
Yeah, so there is so the way we look at depression treatment, we look at it in a holistic point of view. We look about the biological, which is the chemical changes, and that usually happen with moderate to severe depression, rarely in the mild, but sometimes in relapsing mild. We look about the psychological part, which is, we usually focus on something called cognitive behavioral therapy. And then the social part or the environment, we usually look about reducing stress and healthier lifestyle, which include, exercise. Exercise is a big one, a healthier diet. And usually we say things like yoga, meditation, or spiritually, I'm not talking from a spiritual point of view, but praying, usually we know it has a very positive impact on depression, according to science.
Thank you very much. I will move to some private questions now. This person says they have a family member who is exhibiting depressive symptoms, but they will refuse to go to the doctor. What can I say to them to support them? So
patients or people who have depression, they have few things in their mind. One, they think it's their fault, they need to be stronger, so they think that is a weakness. Number two, some patients, they feel like it's religiously, I need to pray more, and as if this one is because I'm not a good person or something like that. And the third one is patients, sometimes when they are depressed, they would say they don't deserve to get better. So I need to tackle those areas. I need to see what's stopping them. And I need to medicalize it because it's a medical condition. And yes, I hear a lot of people, they say to me, yes, I have a family member that is not going to do this, not going to do that. What can I do? I would say we don't tend to negotiate if somebody has really high blood sugar. We tend to make sure we find a way to get them to get the treatment. I don't take on board if they say, I don't want. If a family member in my family says, I don't want to go see somebody and their blood sugar is sky high, I wouldn't listen to them. I don't know. I will find a way. And with depression, we ourselves are afraid because we're not sure. So I would say we need to be more assertive, and it doesn't have to be a psychiatrist. Family physician with good knowledge, can be a starting point, because that would reduce the stigma significantly less. But they need to see the family physicians that has a good knowledge of mental health. We don't want to go to one and say, "Oh no, nothing with you," and just go home. So.
Just to kind of reiterate what Dr. Samer said, yes, it's not uncommon for people sometimes to come to my clinic. They may have migraines, but when I really start talking to them, they do have signs of depression, hopelessness, worthlessness, guilt, feeling of sadness, loneliness. And there's oftentimes I will start them on an antidepressant, and they do get better. A lot of times they do get better. So I think once they notice how they improve, then they come back. They'll come and they see the difference. They notice how their lives have changed. And so initially they may be afraid to come, but I think seeing a physician who has experience, or who at least knows how to at least approach this problem, can help reduce the stigma.
Thank you. Yeah, actually, I think you've covered the next question, but I will ask it anyway. Is my migraine treatment causing depressive thoughts? Should I come and see you, Dr. Ahmed, to talk about it?
I have no problem. I welcome anyone who comes to my clinic. If you have depression, I can try to approach it. We can try to figure out what are your signs, what are your symptoms, and we can try a treatment, and if it helps, why not? If it's treatment resistant, or if it's harder, we may need the help of experts, a psychiatrist like Dr. Samer, and then we would refer you to a psychiatrist for more harder to treat depression.
Dr. Samer, again, still in private questions. How long do you typically see people with depression recovering?
So, like any condition we have, early treatment and full treatment would more likely get you to a full recovery. If we treat it late, or we treat it partially, or we treat it on and off, more likely to become a chronic illness. So the rule is you need to be well, fully well. So what I would say, fully well, symptom-free, full recovery, plus 6 months maintenance period. Then we can reduce and stop medication. First episode. Second episode, it becomes longer. So the first episode is 6 to 12 months. Second episode, 12 to 24 months. So that's why we want to treat and not have second episode. I don't want people to have to be on the 5th episode, because studies and research and science doesn't tell me what to do with third episode, how long we need to treat. So that will be depending on the physician and situation. So it's 6 months, 1 year minimum. Then after the second episode, just up to the physician and the patient, of course.
Thank you very much. My sleep is becoming bad. Is this causing migraines, or is this causing depression, or both?
So can you repeat that?
My sleep is bad. Is getting bad.
Okay.
Is this the cause of migraines, or is this the cause of depression?
I missed the first part. My what is getting bad?
My sleep.
Oh, my sleep is getting bad.
Okay, sorry, yeah. Okay. Your sleep. Your sleep is getting... So sleep, lack of sleep doesn't cause depression. It might cause depressed mood a little bit, but lack of sleep is a sign of depression. So I need to make sure it is not depression and there's other symptoms. So it's good to screen for it.
And as Dr. Deep K said in one of the previous webinars, sleep hygiene is very important for the treatment of migraine. It can actually cause migraines, and sometimes just by getting better sleep, organizing your sleep schedule, if you can't sleep, get out of bed, go outside, go to the living room, do something, read a book, and then try to go back to sleep. This can also help with your treatment of migraine.
Dr. Samer, another private question, do you recommend keeping a depression diary to know when I'm depressed and what happened during that day?
Yes, it's absolutely. That's part of the cognitive behavioral therapy is to keep what we call it a mood diary. So a mood diary, so you have a diary, a private diary, you put some details about each day, and that would help us to recognize what are the triggers at times that make things worse and help with the therapy. Obviously, it will tell us, because sometimes when people, they are depressed one day, they forget that they had a good 5 days, that before that they are quite well, so they feel negative about everything. So when they look at the diary, they see, oh, actually, it was the first 1 month, it was 30 days I was depressed. Second month, actually, I was only depressed 7 days. So that tells me it's a good, hopeful bit for the future. So it helps to train the brain that it is recovering.
What about supplements? Are there anything you can take off the shelf which can help alleviate this?
So supplements, with the exceptions of St. John's wort, with Ashbet St. John's, all are useless. So there's nothing. There's no evidence. They are useless. All of that. St. John's wort is exactly like the common medications that we have, SSRIs, which is Cipralex and Zoloft and all those medications. However, it has more side effects and more drug interaction and less efficacy. So actually, it is dangerous, even though it's a supplement and it's natural. It is definitely more dangerous than medication, more side effects, more drug interaction, less efficacy, and actually we are not assured about the quality, because pharmaceutical, with all their good and bad, at least we know when we have the tablet, it's 10 milligram, it is actually 10 milligram. There's high monitoring, while with supplements, there's almost no monitoring. So I would not recommend at all, but I'm just telling you the science, there's only one thing. Everything else is useless. Even omega-3, which has some tiny bit of evidence, but it's similar to placebo, and the omega-3 is good for everything else, but is not a treatment for depression. So I would say, have it, it's good, but it's not treatment for depression.
Thank you. Is there a significant increase of depression and anxiety cases among frontline healthcare workers in the UAE? And how do we implement a surveillance program of these groups?
Did you say COVID-19, sorry?
No, I'll repeat again. Is there a significant increase of depression and anxiety cases amongst frontline healthcare workers in the UAE?
Okay.
And how do we implement a surveillance program among these groups?
So there, when you say frontline, because usually when we say frontline is now we talk about the pandemic and COVID-19. So interesting enough, in the UAE, especially I think in the Emirates of Abu Dhabi, Saha has been working very hard with the Department of Health and the Public Health Department as well here to have a support sessions for all Saha's employees, which is very, very, very interesting program, very helpful, weekly webinar, and they're having easy access for the doctors to give them support to the healthcare professionals. Now we know that دائرة التنمية والمجتمع in Abu Dhabi, also they're having a big program to support people in the Emirates about, they say, because you care, أنت مهم, I think the name, and we did some videos for that to kind of raise awareness about mental health in all levels. We even did that in a lot of languages, including to workers and to laborers. So we did that for example, in Pakistani and other languages. So there is a lot of work now to raise awareness, which is amazing for me to see. But healthcare workers frontline, they are exactly the same as everybody. They are high risk, because everybody is high risk when we talk about 1 in 6. With the pandemic, it is their higher risk, of course.
Yes, thank you very much. Is there any alternative way to relieve the headache other than medication, as the patient will not stop taking his medication?
Dr. Ahmed, I'll leave that to you.
Thank you. Well, what I would suggest is, on one of our previous webinars where we had Dr. Deep Kaid, he actually spoke in details about ways and mechanisms of negative triggers that can cause migraines and ways to avoid them or ways to alternate your lifestyle. And there was another webinar that we did before that with Dr. Mustafa Shara, where he talked about positive lifestyles in order to reduce headaches. So in summary, I would suggest there are different techniques that someone can use both positively and eliminate the negative techniques in order to improve your headaches. And I would refer you to those webinars in order to get more information. And we are working to make those webinars live. It is a work in progress, but hopefully they will be live soon. Thank you.
Yes, thank you. Hopefully soon we'll be able to share all these educational webinars, free access to all on a free platform that we will be announcing very soon. We only have a couple more questions. Some antidepressants have suicidal tendencies. How to tackle it when such a med is given to a fellow who is already depressed?
Okay, so that's probably the most controversial topics that we have, because when we look at depression and we give medication takes about a week to 2 weeks to work. So if I have somebody who's severely depressed going down, I give them medication here, then they continue to go down. So I would say the medication did not start working, and part of going down, that's where the suicidal thoughts comes in. At times, suicidal thought comes when people are so severely depressed and they are suicidal, but they don't have the energy to act on their suicidal thoughts. When I give them medications, they start to feel better energy-wise, but the cognitive and suicidal thoughts are still there, so they have that. So that we have to be very careful with the severely depressed one with suicidal thoughts. And rarely, when you start medication, it causes a little bit of agitation and restlessness, and that usually is a risk of suicidal deaths. But I would not say they are something that when I give antidepressant, it's something that I should be scared about, is like being suicidal. I would say that would be the same thing that I'll be scared about any medication I might have, and I would be worried about side effects from them that are super rare. But it's not a reason not to give treatment.
Thank you very much. And no, we have a couple more questions. Is being impatient, even in the simplest things, an early sign of depression?
Impatient, so I would assume impatient is the question if it's for me. Impatient because of a psychiatric condition. We rarely have anybody impatient, even in the UAE, unless they have very severe symptoms. So we tend to
impatient. I am.
Oh, impatient. It might be so. Yes, I mean, I've got, I'm sure a lot of people are impatient. If they are impatient, by itself and nothing else, and they're happy going to Yas Water World or in Ferrari World, and they're full of energy, I would say, and they want just to jump the queues because they're impatient, I would say, no, that's not depression. But if it comes with the other symptoms, then yes, possibly.
I think one important factor for most mental health disorders are if it's affecting your quality of life or if it's changing your life. If it's negatively affecting your life, then it's more likely to be an illness. Is that correct, Dr. Samir?
Yes, it's so. Depression is when something affecting. So all the symptoms that have to affect our functioning on our social, personal, or work life.
Okay, thank you.
Thank you very much. Well, there's just one last question. We finished in time, so I will ask it. Is homeopathy effective in relieving headaches?
To my knowledge, homeopathy or essential oils, there are no studies that I know of. That when I mean studies, I'm talking large-scale, randomized, double-blinded, placebo-controlled trials looking at homeopathy. You may find some anecdotal evidence where someone says, I tried homeopathy or essential oils and I got better, but this is not scientifically based, so you cannot come up with a scientific answer to that question. But does it hurt? Probably not. But does it help? Probably. I don't. As of now, I don't recommend it.
Thank you very much. Well, that is all the questions that we have for today. Before I pass you back to Dr. Samer and Dr. Ahmed for their final closing comments, I'd like to thank you all for joining us. We had over 230 attendees joining us live today. The video recording is available for the next 4 days. Will be sent to you after the webinar has been complete. Next week, we have a very interesting lecture on headaches. This is Society's Perspective and COVID Perspective on Migraines with Dr. Jazim Al-Hashel from Kuwait. At the same time next week, we'll be sending you a link for that closer to the time. And I would now like to pass you back to Dr. Ahmed Shatila and Dr. Samer Makhoul for their final closing comments on the webinar.
Dr. Samer, anything you'd like to say?
It's something very simple. Depression is an illness. Depression is something that we all are possibly might come and across it, either our personal life, ourself, our family. And if I'm going to take statistic, I'm almost certain that every family would have 1, 2, or 3 people with depression. So it is a condition that needs treatment. Stigma is high, but treatment is effective, and we need to support all people to get treated, to get them well back to their life, because it's one of those horrible conditions that if you're suffering alone, it feels like, like torture, and that's why people at times feel like they wish they are dead and they want to end their life. But we are very good in treating depression, and please seek help from your nearest doctor, nearest healthcare professional to get better if you have depression.
Thank you, Dr. Samer. I would just like to reiterate what he said. Depression is catastrophic. It can destroy families, it can destroy lives, and end result sometimes of depression, suicide, is even just worse than, it can also be just as severe. It's devastating. And we do have treatments, and we do have experts who are able to treat depression effectively and very well. And as we mentioned, there is a link between migraines and depression. You may suffer from migraines, you may suffer from depression, you may suffer from them both at the same time. So you should get treated, you should see a neurologist, you should see a psychiatrist. Don't be afraid. There's no shame in admitting that you have an illness. It's medical at the end of the day. And with that, I would like to thank everybody for joining this webinar tonight. I would like to, once again, thank Lily for sponsoring this webinar. I would like to thank SSMC for hosting it. And finally, Gerard from Focus Gold for organizing this webinar. And thank you all. Good night. As-salama.
Good night. As-salama. Keep safe, everyone.
And finally, Dr. Samer, if people want to make an appointment with you, Dr. Samer, to discuss these issues, where can they find you?
We are based at the American Center for Psychiatry and Neurology in Abu Dhabi, in Dubai, and in Al Ain. But please go to anybody near you, just get help.
Thank you.
Thank you.
Thank you all. I wish you all a safe and good night wherever you are in the world. I'm now ending this webinar.
Ma salama.
Bye.